A 32-year-old gentleman with atrial flutter was suspected of having an atrial septal defect, ASD, based on catheterization. Right ventricular enlargement raised suspicion of ASD. Contrast study showed the passage of a large amount of contrast across the inner atrial septum, but the subcostal view was inconsistent with ASD. This suggests the presence of a patent foramen ovale, PFO. This brings us to an important question. What is the cause of the RV enlargement? Let's dive into the transesophageal echo TEE views. A large PFO is seen here, but it doesn't explain the right ventricular enlargement. This 3D view of the atrial septum shows absence of ASD and the pattern of a PFO. In this view, the right ventricular outflow tract RVD is dilated and severely dysfunctional, with areas of thinning. This is a case of arrhythmogenic right ventricular dysplasia, ARVD. And this 3D confirms the findings. In ARVD, the right ventricular undergoes both structural and functional changes, including dilation, especially regional dilation, and right ventricular dysfunction. This can lead to aneurysms, particularly in the right ventricular outflow tract, apex, or subtricuspid region. Myocardial thinning occurs due to fatty replacement of the myocardium, and there is often akinesia, dyskinesia, or hypokinesia of RV wall. Nowadays, the disease is referred to as arrhythmogenic cardiomyopathy, ACM, because the pathology is not exclusive to the right ventricle. Many patients develop biventricular involvement, as seen in this case. In some instances, the left ventricular may be more affected than the right, which is referred to as left-dominant arrhythmogenic cardiomyopathy, in contrast to biventricular ACM or classic ARVD.